Hello, hi, and greetings everyone. This is Dilip. Once again, welcome back to another session. After quite a long time, I'm doing a YouTube session basically. I wanted to do on the 2020 ACLS update to be precise. I think I am audible because there will be some lag in the YouTube usually. So hopefully I am audible and you can see me as well, right? Am I audible? People who are there, people who are listening, can you see that I'm audible? Cool. Okay. Can people see me? And is the audio visual aids okay for you guys? Okay, thank you, Dr. Bhardivel. Fine. So we'll be actually discussing on the ACLS 2020 update. There is not much change, to be honest. There are quite a few things which were on the pipeline when they were about to give the 2015 guidelines itself. But nevertheless, 2020 had a few changes which were on the pipeline, but not that much dramatic. You don't need to worry about that. So I'll just be telling on what are the changes that have happened in the recent update that have been given in 2020. There has been separate files as well for that you can go through, which is present in the online. At the same time, what could be potential questions that you can get in the exams? That's what I'm going to discuss. I think I have already discussed quite a bit about the cardiac arrest and life support algorithms quite a few months back, maybe a couple of months back. I think I've discussed on the ACLS guidelines. Just the update part alone, let us try to discuss in this particular section. So what we are going to discuss, let me write the topic. We are going to do the ACLS 2020 update. So I think I can reduce the size a little bit. Okay, so this is what we're going to do. So only the update part. So the majority of the chunk is going to remain the same. It's not that different compared to the previous. So let us start with that. So to begin with, we know how to begin with an ACLS and what is the things that has to be done in the basic life support, what are things that has to be done in the advanced life support. So but nevertheless, as far as the adult algorithm is concerned, there is not much change, to be honest. But pediatric, they have changed quite a bit. But as far as adult is concerned, they have really not changed that much. So let us start with the basic ACLS life support algorithms in the first place. To begin with, we need to go back to the old, and wherever there is something new, let me try to update that only. So to start with, we know, especially whenever the patient becomes unresponsive, irrespective of the location, we need to start with the pulse assessment. So first of all, whenever the patient collapses, uh, so if the patient is unresponsive, then only you go to the next step. Suppose if the patient is responsive directly, suppose if the patient is responsive in the first place, you're not going to do any other thing at all. You're just going to activate the emergencies medical services just to take them to the hospital, or if they are in the hospital already, just assess why the patient collapsed in the first place. So once the patient is unresponsive, then next step is to see for the pulse, whether the pulse is there or not. So pulse felt or pulse not felt, that's what we're going to do next. As if the pulse is felt, then again I'm not going to do anything. I'm just going to assess the cause of the collapse and unresponsiveness. But nevertheless, once the pulse is not felt, suppose if I'm not able to feel the pulse, so this is a situation where I need to consider this patient as a cardiac arrest one. So this is something which we have discussed already. I think people who have attended my previous lecture on the ACLS and BLF must be able to answer this. So suppose this is the area where we call the patient or define the patient as cardiac arrest. So there are many things that will come under this cardiac arrest. It could be a pulseless VT, it could be a pulseless VF, or it could be a bradycardia without a pulse, or maybe it could be a asystole, or probably it could be a pulseless electrical activity as well, whatever may be the case. So this, whenever the patient's pulse is not felt, so this is where we define the patient to have a cardiac arrest, irrespective of the breathing status. So when the patient is not having a pulse, we call it as a cardiac arrest. So once the patient is encountering a cardiac arrest, once you define that this particular individual is actually having a cardiac arrest, the next step is actually to start the CPR. So you're going to start the CPR directly. So you're going to start with the cardiopulmonary resuscitation. So the most important, we know that. So whenever CPR is started, irrespective of the place or irrespective of the location. So when the CPR has been started, so what you're going to do is you're going to give more importance to the chest compressions. That's really, really important. Chest compressions. And again, once again, the update also has been clearly emphasizing on the importance of the chest compressions, which is really, really, really important. The chest compressions are the most important component of any CPR, then followed by the airway, then probably followed by the breathing. So this is something which we know already. This is something that have been done from the 2010 guidelines itself. There is no much change with regards to the CAB protocol in this current 2020 update as well. And we need to know about the chest compression to rescue breath ratio, which had a little bit of changes in 2015, and there is one small change in the pediatric life support only with respect to the rescue breaths. But nevertheless, the chest compression to rescue breath ratio when the patient is not in ACLS, suppose if the patient is in BLS and the patient is not having any advanced airway, since I can write if the patient is having no advanced airway, in the sense no endotracheal tube, or probably the patient is not having any laryngeal mask airway. So in this setting, there is a particular ratio that we need to give it, and that ratio has not changed at all. To be precise, first of all, if it's an adult individual, irrespective of the number of rescuers, it's always 30:2. Doesn't matter. We know that there is no change in that. And similarly in pediatrics, once again, there is no change in that. Even in pediatrics, it's going to be either 30:2 or 15:2. So this is what we are doing basically. So when will you do 30:2 ratio? So 30:2 typically if the patient is being rescued by a single rescuer, or 15:2 if the patient is being rescued by more than one rescuer. Probably if there is a double rescuer or more than one rescuer, so in that setting you can keep the ratio as 15:2. And similarly neonat, it has not changed that much. So it is still been and approximately around 3:1. So this is something that has not changed as well as per the current update is concerned. So there's no much change. But there is one change that has happened, that when the patient is in ACLS and having an advanced airway, suppose the patient is having an advanced airway, nevertheless, suppose if the patient is already having an endotracheal tube, for example, we have something called an in-hospital cardiac arrest. In this situation, the patient is having an advanced airway like endotracheal tube or probably a laryngeal mask airway. In this particular situation, the amount of chest compressions has been defined clearly. So it should be typically at least 100 to 120 per minute. This is something that is old. Typically 100 to 120 per minute. Here also the chest compressions has been the same. It should be 100 to 120 per minute with the chest compression to rescue breath ratio of 30:2. We know that. And at the same time, we need to know the depth of compressions as well. As far as the depth of compressions is concerned, it is typically 2 inches, which has not been changed. That is approximately 5 centimeter, which has not been changed at all in the first place. And similarly, again, the depth of compression that is optimal as per the update is also 2 inches. There is no much change with regards to that. And the number of rescue breaths that you're going to give has been the same for pediatrics as well as the adults, but in the recent update, the pediatrics is actually different, quite different from the adults. For example, if it's an adult individual, so the number of rescue breaths will be approximately 10 to 12 per minute, but a lot of guidelines clearly tell that it's better to give approximately exactly 10 per minute. So 10 per minute, but it can be anywhere ranging from 10 to 12 per minute. So this is the case whenever you are having an advanced airway. So if you're having an advanced airway, this should be the rule. So it should be 10 per minute or probably 10 to 12 per minute. So usually you give one breath every maybe 5 to 6 seconds. 5 to 6 seconds. So this is what the rule is. So in my hospital, for example, if you take my residents will be getting trained to give one breath every 6 seconds rather than giving every 5 seconds. But nevertheless, so if one breath every 5 to 6 seconds is considered to be extremely optimal as far as adults are concerned. But there is one small change that has been made in the pediatrics. Previously, even in pediatric age group, it's been suggested to have a rescue breath of approximately 10 to 12 per minute. But right now in pediatrics, there has been a small change that's been done. So where the number of rescue breaths has been probably increased a little bit, so that they can give every 3 to 5 seconds. So in the sense where typically you can give up to 12 to 20 breaths per minute approximately. So this is what something that has been suggested. This is considered to be a little bit of change compared to the previous one. So there are substantial number of changes in the pediatric guidelines rather than that of the adult guidelines, which we'll be discussing subsequently. But in pediatrics, like rather than giving every 5 to 6 seconds, it's been suggested that you can give rescue breaths every 3 to 5 seconds. So that is something that has been suggested rather than giving at every 5 to 6 seconds compared to the adults. So nevertheless, once you start with the CPR, you are going to continue with the CPR irrespective of whatever happens. Remember, the most important component of the CPR is this chest compressions, and this chest compressions has to be uninterrupted. So there are quite a few definitions for how much it should be uninterrupted. Like for example, if you are in a hospital setting, you're getting an in-hospital cardiac arrest, then in this situation it should be completely uninterrupted, and you have to rotate the person who's giving the chest compressions every 2 to 3 minutes, because otherwise they'll go for fatigue and probably even some muscle injury for the person who's giving continuous CPR. So it's better to rotate the individuals. That's been there already. And at the same time, suppose if you are only a lone individual, maybe in the out of hospital cardiac arrest situation where you're trying to give a CPR, probably in that kind of a situation, your interruptions should be less than 10 seconds. Remember, this is typically applicable only for people who are engaged in out of hospital cardiac arrest where they're trying to give rescue breath and chest compressions at the same time. So when you're giving a rescue breath, that is the time where you might need to interrupt your chest compressions. So this is applicable only for OHCA. But as far as IHCA is concerned, IHCA stands for in-hospital cardiac arrest, whereas OHCA stands for out-of-hospital cardiac arrest. As far as out-of-hospital cardiac arrest is concerned, your interruption should be less than 10 seconds. And as far as in-hospital cardiac arrest is concerned, your interruption should never be there practically, and it should be completely uninterrupted. That's the key point. And at the same time, so you need to know that chest compressions are the ones that are going to increase the survival, increase the rate of return of spontaneous circulation, which we'll be discussing subsequently. And at the same time, this is the one that we are actually trying to do in the best possible way. So that's why the interruption should not be there at all. So you're going to continue with the CPR in the same rescue breath ratio until the AED arrives to the scene. So remember, this is impractical scenario as far as India is concerned. And can anyone tell what are the differences between AED and probable manual defibrillator? Because we have two things. One is called the AED, and probably second one we have something called a manual defibrillator. So you need to tell. So what is the difference between an automated external defibrillator versus a manual defibrillator in that matters? For that matters. So what is the difference? I'm waiting for your answers. And I think I can quite a bit change here. I think it's basically around 2 to 3 seconds. So every 2 to 3 seconds. So the recommended number of rescue breaths that has been around 20 to 30 breaths per minute. So this is the one thing that I want you to remember. Nevertheless, before I get your answers. So this is something I need to re-emphasize again. So every 2 to 3 seconds. And the total breath of approximately 20 to 30 per minute. So that's the thing that has changed in the pediatrics. Previously, pediatrics was also this approximately 10 to 12 per minute. So this is something that has been changed. So that's I want to re-emphasize one more time. Okay. Nevertheless, Alicia is telling diagnosis of rhythm as shockable or not. Actually, no. Let me go back to another page and discuss on. This is the difference between an AED and a manual defibrillator. The automatic external defibrillator is completely automatic. So one important thing to know is that this is something that can be operated by a layman or probably. it doesn't need that much of training. That's the most important thing. Even you can train a layman very easily who's not even into the medical field. So, but this is something called as a manual defibrillator, and that's really important because this is something that is available in the hospitals most of the times, and this needs a lot of training. In fact, a very vigorous training is required to operate a manual defibrillator in the first place. So this is a manual defibrillator. So usually it delivers only one kind of shock. It delivers high energy shock. The shock usually that is delivered is most of the times fixed, and it delivers only defibrillation. Defibrillation means it's basically unsynchronized. It is not going to get synchronized by any chance. But as far as the manual is concerned, the amount of shock can be variable, which means you can deliver 100 joules, you can deliver 200 joules, you can deliver 250 joules, again depending on the type of arrhythmia. So you can set the amount of shock, so depending on the type of arrhythmia. And at the same time, point number 3 is the fact that it can do a synchronized cardioversion versus it can do an unsynchronized cardioversion as well. I mean, if there is there will be a button called sync here. Suppose if you just want to press the sync button and you can start the shock process. So essentially it is either a synchronized or it can be unsynchronized, but here you can only do an unsynchronized cardioversion, which is typically referred to as something called as a defibrillation. And plus or minus, it has a lot of other functions, like probably it can do pacing function also. It can do many other functions. For example, there is something called a transcutaneous pacing. Even if you have a transvenous leads, then it can actually, some manual defibrillators can do a transvenous pacing as well, but nevertheless, it can do some of the defibrillator machines, manual defibrillators can do additional pacing as well. So there are a lot of differences between automatic and manual. Most of the settings, especially if the patient is having out of hospital cardiac arrest, your automated defibrillators are the key, because this is something that is available in many shopping malls, and most of the times in Indian settings, it's not that commonly available, but in most of the Western settings, in many of the outside areas and out of hospital cardiac arrest also, this automated external defibrillator is readily available and very commonly available. So not a problem at all. It can detect the rhythm automatically. Like when it detects a pulseless VT or a VF, it automatically delivers a shock. So this is quite easy for people who don't have a good medical expertise. But this has to be used only by personnel who's going to have a good medical knowledge. I mean, which means it can be used only in the in-hospital cardiac arrest setting. So I think this is the mission that you would have seen a lot of times in your casualty or probably in your wards as well, on yellow color mission that will be there all the time. And nevertheless, so this is the idea of giving a chest compression. So how to give a chest compressions? First of all, your arms should be extended, which is very, very important, number one. And at the same time, you should clasp the fingers over the other one. So it's better to clasp the fingers. Maybe you can make like a knuckle lock as well, not a problem at all. So, and where will you compress is on the middle of the sternum. So mid sternum is the place where you need to compress as far as the CPR is concerned. And typically, as I told you, the compression rate is 100 to 120 per minute. Or if it's an adult, I am usually going to go for a ratio of 30:2. And at the same time, my compression should be at least for 2 inches. A good compression should not have any injury, major injury, but there have been reports of some fractures, but it's been extremely uncommon. And second, this is how you need to give a rescue breath. Suppose if you have a bag mask ventilation, then it's not a problem, not an issue at all. Suppose if you do not have a bag mask ventilation for that matters, then you need to give a mouth-to-mouth resuscitation. Means the one thing that often many people do miss is this nose that should be pinched. So which means you should not allow the air to escape out through the nose. So that's why you should always close the nose. And this is the head tilt chin lift maneuver that's been done, which is again quite important. So that is the head tilt chin lift maneuver. And finally, you need to, whenever you're going to give the mouth-to-mouth resuscitation, you need to watch for the chest rise. That's very important. If the chest doesn't rise properly, then again you're not giving a proper resuscitation in any airway. So probably it could be an advanced airway, it could be a basic airway, or it could be no airway and you're giving a mouth-to-mouth resuscitation. This chest rise is really, really important. So these are the basic life support protocols, and these are very basic to basic things, and where to compress and all this stuff. And these are the chains of survival. There has been one chain of survival that's been added in the recent algorithm, both out of hospital as well as in hospital cardiac arrest algorithm, is the recovery part. This is something that is new. Previously, we had only 5 different chains of survival, but currently we have the 6th chain of survival that has been added, that is the post-ROC recovery. So actually we are trying to make the candidates recover better. So we have some algorithms for how to really do recovery assets. So let us go back to our original discussion. So now you know what you mean by a defibrillator, what is the difference between manual and automated defibrillators. Then we need to know how to give a chest compression, and we need to know, we also know how to give a rescue breath for that matters, and what is the 6th chain of survival that's been added in the new protocol, that is the recovery part, apart from the usual 5 chains of algorithm which has been already there. And once the AED arrives, we know what to do. So once the automatic external defibrillator arrives, or probably even a manual defibrillator arrives, I don't really bother. So what we need to do is to really see the rhythm. So that's what's going to be the most important thing and the very crucial aspect of the CPR. So once you see the rhythm could be anything. So suppose if you want to know the differential diagnosis of cardiac arrest rhythm, it could be a pulseless VT. So which means there could be a VT with a pulse. So that will be dealt separately. If there is a pulse, it won't be coming under cardiac arrest itself in the first place. Then you do have a ventricular fibrillation, you do have a pulseless electrical activity, and you do have something called an asystole, and sometimes, very rarely, it could be bradycardia without a pulse, a severe bradycardia without a pulse. So these are the 5 different things that you can encounter whenever the patient is in a cardiac arrest, which means all these situations will not have a pulse. They won't have a pulse. So whenever there is no pulse, that is a point where you're going to call this patient to have probably a cardiac arrest in the first place. So see the rhythm. So as far as the rhythm is concerned, even though I'm not writing the exact algorithm, this will be very useful. You need to know whether the patient is having a shockable rhythm or probably the patient is having a non-shockable rhythm. Non-shockable rhythm. So these are 2 things that we have to know. As far as the shockable rhythm is concerned, there are only 2 things that are basically shockable. One is referred to as something called as a pulseless VT and a ventricular fibrillation. And second thing, I mean, there are a lot of other things that is non-shockable, like pulseless electrical activity, including the bradycardia without a pulse, or probably even asystole. So asystole means a flat line. Pulseless electrical activity means any other rhythm without a pulse. So this is basically a non-shockable rhythm where you cannot deliver a shock in this perspective. Suppose if the patient is having a shockable rhythm, so the next step is of course going to be the shock. So that's really important. Next step is going to be the shock. There's no doubt about that. So every minute you waste without shocking a shockable rhythm, the risk of patient going for death is very high. At the same time, the ability to achieve that ROC is going to be very poor. So that's why whenever you get a patient to know that the patient is having a shockable rhythm, it's better that you shock ASAP. So that is the next step. So once you have shocked, if you want to go for the next step is always CPR, that you have to resume. Don't look at the monitor and see whether the rhythm has achieved or not. I mean, you will be looking at the rhythm, but don't try to underestimate this resumption of the CPR after giving a shock in the first place. So at the same time, you're also, once you have given a shock, you're also going to really see whether the patient has achieved ROC or not. Is there any signs of ROC? So before that, I can write next step will be again seeing the rhythm. So whether it is shockable or not. At the same time, while looking for the rhythm after the CPR of 2 minutes, I'm going to see whether the patient has achieved ROC. Is there any signs of ROC? Any signs of ROC is there or not? So while looking at the rhythm, but this CPR of 2 minutes is mandatory even after shock. But the problem is, once you do a shock, it's a natural tendency to always look for the signs of ROC, which should be really avoided. That again wastes a crucial time, especially when you are in the setting of a cardiac arrest. So always resume with the CPR. That's really important. Suppose if the patient is having a non-shockable rhythm, it's straightforward. You're going to do CPR for 2 minutes because this rhythm cannot be shocked. And once you have done the CPR for 2 minutes, you have to check for the rhythm. And based on that, once again, the algorithm becomes now whether it's a shockable rhythm or it's a non-shockable rhythm. And there has been quite a few updates as far as the drugs are concerned. They have re-emphasized the use of epinephrine, which we'll be discussing subsequently. So let us write on the drugs part so that we're going to use. There are a lot of drugs that have been used. First of all, let us see what are the things that have been completely removed from the CPR guidelines from 2015 time itself. The first thing that you need to know is no atropine has been recommended in the routine CPR. Number 2, no vasopressin. So vasopressin previously considered to be an alternative for adrenaline, epinephrine, but right now there is no vasopressin. This been there from 2010 guidelines itself. Number 3, third thing is there is no cricoid pressure. So especially when you are intubating the patient, or probably when you are not intubating the patient, when you are using a laryngeal mask RV or doing a CPR, there is no cricoid pressure. That is the Selig maneuver. So there is nothing like that currently recommended. These are the 3 no's that you need to know that has been completely removed from any CPR guidelines right from 2010 and 2015 time. So that same thing has been applied in the current guidelines also. But as far as the drugs part is concerned, there are quite a few things that you need to know. So there are 3 drugs that have been used. One is the adrenaline, that is nothing but epinephrine. And the second is, of course, antiarrhythmic drugs. Antiarrhythmic drugs that you can use. And as far as adrenaline is concerned, so they re-emphasize the use of adrenaline. I mean, even if you see my previous CPR guidelines, even if you see my previous ACLS protocol video, I would have clearly mentioned adrenaline is very important for non-shockable rhythms compared to that of shockable rhythms. So if you, wanted to know where adrenaline is more beneficial, whether in non-shockable or in shockable rhythm, I can be extremely clear in that aspect that it is usually more emphasized in non-shockable rhythms compared to that of shockable rhythms. So what is the timing of adrenaline? So that is something again re-emphasized. I think I mentioned all these things in the previous guidelines, previous video itself, because there is, even though they have re-emphasized the use of adrenaline in non-shockable rhythms, even though they have re-emphasized that in non-shockable rhythms, the timing should be ASAP, that is as soon as possible. Compared to shockable rhythms, usually we give adrenaline after the first shock, after the second shock. After the second shock, the same thing has been re-emphasized once again, but this has been something critical. So they have proved that adrenaline, if you give in non-shockable rhythms as soon as possible without wasting time, so then the outcomes are much better, especially in pediatric age group, in pediatric advanced life support. So they are actually trying to give adrenaline within 5 minutes. So this is something that has been added new. So this could be the question in your exam. So especially the INI-CET might be asking something with regards to this, because this is something that has been released only a week ago. So, but in adults, it's still, they are suggesting you to give ASAP. There's no particular timing that's been given in adults, but they are telling the more faster you give adrenaline, the more better efficacious it is. And at the same time, in pediatrics, it's better that you give within 5 minutes. So that's what the guidelines are suggesting in the first place. And as far as the dosing is concerned, they have not changed the dose that much, to be honest, as the dosing is concerned. So dosing, depending on the availability, whether you have a IV or IO route. Many of the times you might be wondering like what you will be doing after the first shock. So please understand that after the first shock, while doing a CPR, suppose if you are, you might be wondering, so what you'll be doing after the first shock. So the moment you know it's a shockable rhythm, you're going to shock the patient. There's no doubt about that. After the first shock, you're going to do CPR for 2 minutes. Suppose if you are doing the CPR for 2 minutes after the first shock, this is the time where you are going to achieve an IV access. It's been very clear that IV access is much, much superior than intraosseous access. This is something that is new, that's been added once again. IV access is much, much superior compared to IO access. Previously, they told that IV access and IO access are almost having equal efficacy, that is intraosseous access. But right now, it's been clear that the IV access is much superior. So whenever possible, it's always better that you try to achieve an intravenous access rather than an intraosseous access. As far as the dosing is concerned, suppose if the patient is having as far as the dosing is concerned, if the patient is having a IV or an IO access, even though it's been clear that IV access is much superior. So as far as dosing is concerned, we're going to use that dose of 0.01 milligram per kilogram. That's the standard dose, or alternatively 0.1 ml per kilogram for standard dose of adrenaline. Typically, we use that diluted adrenaline, that is 1:10,000 adrenaline. We are going to use as an IV, and approximately we can use 1 ml. So this is the standard. but nevertheless, the standard dose that is recommended per kilogram is 0.01 mg per kilogram, or probably 0.1 ml per kilogram. That is the diluted form of adrenaline. That's what you're going to use. And suppose if you don't have an IV or an IO access, suppose if you have only a endotracheal tube in situ, so in that setting you have an endotracheal dose as well. As far as the endotracheal dose is concerned, once again the dose is going to be 0.1 milligram per kilogram, or probably you can use 0.1 ml per kilogram in the standard 1 ml per kilogram adrenaline. So that's what you're going to use. I mean 1 ml per 1 milligram per ml adrenaline. And whether you can repeat this dose or not, again it's same. You can repeat every 3 to 5 minutes, not a problem at all. So every 3 to 5 minutes, in the sense you can repeat with every alternate CPR cycles, because each CPR cycle is going to last for 2 minutes. So every alternate CPR cycles approximately you will be using once in 4 minutes. So that's again something that has not been changed. So but the dosing once again has been very important for years of questions that's been asked in the exams. So this 0.01 mg per kilogram or 0.1 ml per kilogram, is 1:10,000 IV 1 ml. So all these are probable questions in your exams, and it's been asked multiple times in the past. And as far as antiarrhythmics is concerned, there are quite a few things that actually changed in antiarrhythmics. Previously, we believed that amiodarone or lignocaine can be used. So, but remember, this antiarrhythmics can be used only in patients with shockable rhythms. It is not indicated in patients with non-shockable rhythms. So you can use this only in patients who are having shockable rhythms. In the sense, only for pulseless VT and ventricular fibrillation you can use antiarrhythmics. Otherwise, you cannot use. And what are the drugs? There are 2 drugs that's been considered. One is amiodarone and second is lignocaine. Both can be used. Previously in the CPR guidelines, they have told that amiodarone is superior compared to that of lignocaine, especially in the setting of cardiac arrest, but currently it's been proven by substantial number of trials that happened from 2015 to 2016, where they proved that amiodarone is actually equal compared to that of lignocaine, and lignocaine is not inferior to that of amiodarone, especially when it comes to scenarios like cardiac arrest. Suppose if you want to know the dose of amiodarone for that matters, typically we use a 5 mg per kilogram bolus. So this is what you're going to use, and the maximum dose of amiodarone that we generally use is approximately 300 milligram. So this is the usual standard dose of amiodarone that we use in adults. That's 300 milligram. And at the same time, one more important change that's been made is previously they told you can repeat a half dose of amiodarone probably 1 more time, but here you can repeat for 2 more times. 2 more times, which means total of 3 doses. This is something that's been changed compared to the previous guidelines. So total of 3 doses of amiodarone can be given. So right now, so you can repeat 2 more times. So the same 300 milligram dose without reducing the dose of amiodarone, you can repeat up to 3 doses. Not a problem at all. And as far as the lignocaine is concerned, the standard dose of lignocaine is 1 milligram per kilogram. The same principle applies to lignocaine as well. But regarding the repeating of lignocaine, they have not mentioned anything like that. The usual standard dose that we use as far as lignocaine is concerned is 100 milligram. 100 milligram is the usual standard maximum dose as far as lignocaine is concerned. But the usual dose of lignocaine is approximately 1 milligram per kilogram, or you can go up to a maximum of 1.5 milligram per kilogram as well. But antiarrhythmics, once again, it has to be used only in shockable rhythms. It cannot be used in non-shockable rhythms. So that's it. So same thing you're going to repeat again and again. If it's shockable, shock it, do CPR for 2 minutes, and you check the rhythm, see whether it is shockable or not, whether it is shockable or non-shockable. Suppose once again, if you feel it's a shockable rhythm, so the next step will be to deliver a shock again. If it's a non-shockable rhythm, you're going to continue, resume CPR for 2 minutes. And after delivering a shock, once again you resume CPR for 2 minutes. And after this, again see what is the rhythm. So once you see what is the rhythm, now in this particular situation, again it can be shockable or non-shockable. If it's shockable, deliver a shock. If it's non-shockable, resume CPR for 2 minutes. Even after delivering a shock, you're going to give CPR for 2 minutes. That is something which should not be forgotten. At the time of seeing the rhythm, you can also look where the patient has got a sign, any signs of ROSC or not. So there are a lot of signs of ROSC, and there has been quite a few changes that has been done with ROSC is concerned, which we'll be discussing subsequently. But nevertheless, antiarrhythmics, when will you deliver? So what timing? So we have not discussed about the timing of delivery of antiarrhythmics. as far as the CPR is concerned. As far as the timing of the delivery of antiarrhythmics is concerned, usually it is delivered after the third shock. So naturally the question comes, what will you be doing after the second shock? After the second shock, I'll be probably giving adrenaline, and after the first shock, probably I'll be busy in achieving an IV access or probably even an IO access for that matters. So sequentially, if you want to know, suppose if you are having a shockable rhythm, and if somebody asks you what you'll be doing after first shock, typically I'll be achieving IV access. So that's what I'll be doing after first shock. So what you'll be doing after a second shock? It's quite natural to tell that you're going to give epinephrine after second shock. And what you will be doing after third shock? After third shock, I'm going to administer antiarrhythmics like probably amiodarone or probably even a lignocaine for that matters. And what you'll be doing after fourth shock? Fourth shock, I'll go back to epinephrine. After fifth shock, what I'll be doing? After fifth shock, I'll be giving antiarrhythmic once again. I'll be repeating the dose again, because amiodarone I can give total of 3 doses. After sixth shock, I can repeat epinephrine. After seventh shock, I can go back to amiodarone again. After eighth shock, I can give epinephrine. Remember, amiodarone can be given up to a maximum of 3 doses only according to the protocol. After seventh shock, once you give amiodarone for the third time, you cannot give amiodarone once again. So after seventh shock, the moment you give amiodarone, that's it. So beyond that, you cannot give amiodarone. After 8th shock, I'll be giving epinephrine. After 9th shock, nothing. After 10th shock, epinephrine again. After 11th shock, nothing. After 12th shock, epinephrine once again. So amiodarone can be given for a maximum of 3 doses, but epinephrine, there is no ceiling dose. You can give any number of doses of epinephrine for that matters, which is not going to affect your CPR in any way. So, and one more thing that you need to know is to assess the CPR quality. That's really, really important. Assessment of CPR quality. So as far as the CPR quality is concerned, it has to be objective. Objective are more better than subjective assessments. As far as objective assessments is concerned, so this is something that's been added in the new algorithm. So objective assessments are better compared to the subjective assessments. As far as objective assessments are concerned, the one thing is the ETCO2, and second thing is the intra-arterial blood pressure. Remember, ETCO2 can be measured as soon as the advanced airway is placed. Once you have an advanced airway, then ETCO2 can be measured pretty easily, which is also very good. And if you are using intra-arterial blood pressure monitoring, if the patient is already probably on ICU, already in ICU, and having an in-hospital cardiac arrest, in the sense like patient is an ICU guy, was admitted in the ICU, is already having an intra-arterial blood pressure in situ and going for in-hospital cardiac arrest, example in ICU settings, then IABP also becomes really good. So as far as the ETCO2 is concerned, can anyone tell what is the standard and what is the amount of ETCO2 that you have to achieve as far as the cardiac arrest is concerned? Can anyone tell? So what is the amount of ETCO2 that you need to achieve? Yes, correct. So Bharati is telling anything more than 10 millimeter of mercury is enough. So it's considered to be a good quality CPR. And as far as the IABP is concerned, when you are having an intra-arterial blood pressure, so in this situation, your relaxation pressure, remember, when the heart is beating, you can call it as a systolic or a diastolic pressure. When the heart is not beating, I'll be typically calling it as a IABP, that is intra-arterial blood pressure. I will be calling it as a compression pressure and a relaxation pressure. When you compress with when you do a chest compression, it's a compression pressure. When you relax, you're going to have a relaxation pressure. That's really, really important. As far as the relaxation pressure is concerned, it should be at least more than 20 millimeters of mercury. So this is the guideline. So, you can remember this as a rule of 10 and 20. So more than 10 is for the ETCO2. And if you have an intra-arterial blood pressure by chance, then your relaxation pressure should be at least more than 20 millimeters of mercury. So these are the standard objective ways of assessing the CPR quality, which means whenever you have these guideline satisfying, then which means you are having a good CPR quality. So when you can satisfy this, then it means you are probably having a good CPR quality, which is again very important to know. And more importantly, one more thing which I want to tell is, so whenever you are giving chest compression, which I've told you clearly, you need to also be sure that you achieve full recoil of the chest. That's very important. This is a subjective way of telling a CPR quality, full recoil of the chest, and giving 100 to 120, giving a 30:2 ratio, giving 2 inches of depth, and achieving a full recoil of the chest before going for the next compression. All these things tells you that it's a good CPR by subjective assessment, but still guidelines are telling that whenever you can find out the CPR quality objectively, that becomes really, really important. So Divi Prakash is telling 35 to 40 millimeters of mercury as the ETCO2 target, but that is a normal ETCO2, and that's not the case here. So that's a normal ETCO2, but nevertheless, you cannot really tell that 35 to 40 you can achieve in a patient who is suffering from a cardiac arrest, which is a little bit impossible, or literally impossible for that matters. When you achieve 35 to 40, it means you have achieved a return of spontaneous circulation. That's what matters. But nevertheless, so whatever may be the case, you're trying CPR, trying CPR, trying CPR, trying CPR, trying CPR. Ultimately, you achieve an ROC, that is return of spontaneous circulation. As far as ROC is concerned, this is something new as far as the adults is concerned. They have clearly told how to achieve, how to progress when the patient is developed return of spontaneous circulation, which is also something very important to know. So how to assess ROC? How to know where the patient has achieved a return of spontaneous circulation, or a CPR could be a complete failure. So which means the patient has not achieved ROC, means the patient is dead, and declare the patient it's deceased. You're not going to progress further. Suppose if the patient has achieved ROC, that is return of spontaneous circulation, how to assess that the patient has achieved a return of spontaneous circulation? It can be clinical, or it can be through ETCO2 as well. So clinically, or it can be through your blood pressure assessment as well. So as far as the clinical is concerned, you can look for the pulse, you can look for the blood pressure that comes back again, and you can look for the ETCO2 as well, especially if the ETCO2 becomes consistently more than or equal to 40 millimeters of mercury, and it is consistent and persistent. Consistently more than 40 millimeters of mercury, you can again tell that the patient is having ETCO2. So since I've told the BP already, and I can strike out. So assessing the pulse, assessing the blood pressure, or probably the patient will become responsive once again. And you can also tell that if ETCO2 becomes more than 40 and remains persistently more than or equal to 40 millimeters of mercury, so once again you can tell that the patient has achieved ROC for that matter. So once the patient has achieved this return of spontaneous circulation, so in this particular perspective, I need to really go for the post-ROC care. That's really important. Post-ROC care. So what do you mean by the post-ROC care? As far as the post-ROC care is concerned, we have two different phases. One is called as an initial stabilization phase. We have initial stabilization phase. Then after that, we have advanced management phase. So as far as the initial stabilization phase is concerned, first thing is to manage the airway management. As far as airway is concerned, if the endotracheal tube is not placed, you can go for the early ET tube placement. So if it is not placed already, suppose if the patient is not already having endotracheal tube during the initial steps, though in this situation you can try to achieve an early endotracheal tube. So once you have gone for the airway, then monitor the respiratory parameters. So as far as the respiratory parameters is concerned, typically you are going to start with approximately 10 breaths per minute. 10 breaths per minute as the standard respiratory management, and the saturation that you need to target is approximately 92 to 98%. Anything is fine, and nobody is really going to try and reach 100% saturation for that matters. And as far as the PaCO2 is concerned, you can try to achieve a PaCO2 of approximately 35 to 45 millimeters of mercury. 35 to 45 millimeters of mercury. This is the standard PaCO2 target, so you can give ventilation based on this standard respiratory parameters. And remember, the FiO2, your pressures in the ventilator, the tidal volume in the ventilator are all standard. So it is something that is not going to change. Suppose if you want to know what is the tide volume, it can be around 6 to 8 ml per kilogram, even though 6 ml per kilogram is considered to be the standard. As far as pressures is concerned, your plateau pressure should be less than 20 to 30 centimeters of water. As far as FiO2 is concerned, you can start with 100%, then you can titrate accordingly. The faster you come to 60%, the better it is. So according to any guideline. So it's always the standard thing. So there's no much change as far as the ventilatory guidelines are concerned. But the respiratory parameters has been set. A little bit of change is there compared to the previous one, which I don't want to really substantiate, but these are the targets that I'm going to achieve in the first place. Then now after this, you are definitely going to obtain a 12 lead ECG. Suppose in 12 lead ECG, why I want to do a 12 lead ECG is because to assess the need for cardiac intervention. Suppose if the patient is having a STEMI, I can actually take the patient for a cath lab, or usually we don't suggest thrombolysis in this kind of situation, but know whether the patient will need any cardiac intervention further. Any additional cardiac management is needed. So for example, if the patient is having a unstable cardiogenic shock, then I can preferably go for an IABP, intra-aortic balloon counterpulsation. If the patient is having a STEMI, then in that situation I can activate the cath lab and push the patient to a cath lab. Or if the patient is having any severe cardiogenic shock not responding to IABP, or if the EF is extremely low, then I can even consider using a device like a LVAD or probably some other mechanical circulatory support devices I can use. So once I obtain the ECG and know the need for additional cardiac intervention and management, then look for whether the patient is following commands or not, whether the patient is comatose or not, whether the patient is able to follow your commands or not. So if they are able to follow the commands, yes, then you're going to give a standard critical care management, which means the patient has recovered neurologically as well to a large extent. Standard critical care management is needed by then. Suppose the patient does not follow your commands, which means the patient is still in comatose state, then in this situation, then you have to go for additional management, like probably I need to take a CT to know any reversible causes there or not. For example, it could be a hemorrhage, it could be a big ischemic stroke, doesn't matter. So I need to do a CT for various reasons. Even for neuroprognostication, my CT might be very useful, which we'll be talking subsequently. And then I need to do something called a targeted temperature management, that is TTM. Previously, this is also referred to as something called a therapeutic hypothermia. So what do you mean by targeted temperature management? I need to maintain the body temperature approximately around 32 degrees Celsius to 36 degrees Celsius by variety of cooling techniques. There are two types of cooling techniques basically. One is called surface cooling techniques. Second method is core cooling techniques. There are two types of cooling I can use, to be honest. This is the temperature I need to set as far as the TTM is concerned, at least for a minimum of 24 hours approximately. So once I know I'm going to do target temperature management, I can go for a standard critical care management. So let me show you an image of how will you maintain temperature. I think this is one way how we maintain a temperature. So these are the devices that produce that surface cooling. I can show you here. So these are the surface cooling methods, where I can keep a pre-cooled surface cooling pad, or probably I can keep a water bag that will have a tubing. That tubing is actually constantly infusing some cold water and removing some the warmed water that is, once it comes into contact with the body, it's going to become warm, and that water can be removed, and once again the cold water can be circulated in this particular pad so that the surface remains cold. So these are the various ways of surface cooling methods, and we also have some of the core cooling methods. Like for example, the most commonly performed cold cooling method is the IV cold saline. So I know exactly what is the temperature of this saline, so I can actually use some calculations to know what will be the final core temperature. But nevertheless, very commonly what we use is to see the tympanic membrane probe. Once I put a tympanic membrane temperature probe, I'll also be knowing so what will be the core temperature of the patient. So basically, based on the core temperature, which should be adjusted to 32 degrees Celsius to 36 degrees Celsius, I can cool the patient. So this is supposed to have unequivocally a better outcome and increased survival. As far as the neurological recovery is concerned, this is considered to be extremely good. So there are three areas where you can use this therapeutic hypothermia or target temperature management. One is the post-ROSC in cardiac arrest patients. Second is the traumatic brain injury state where the patient will be comatose again, and third is the ischemic stroke patients who are comatose. But remember, ischemic stroke, currently the trials are going on. Currently you should not answer this in exams, but the two areas where you can use the target temperature management and therapeutic hypothermia is your traumatic brain injury, and the most important is the post-ROC, that is the return of spontaneous circulation area. And once we have gone through all these things, the patient consistently remains comatose. So then I need to do something called a neuroprognostication, which means I need to know whether the patient will recover, if at all, or not. So that's what we refer to as a neuroprognostication. As far as the neuroprognostication is concerned, there are quite a few things that can be done and that has to be done. So within the first 24 hours, the most important thing that we do is the CT as a very important neuroprognostication tool. From 24 hours, after 24 hours, there are certain things that you can do. Like for example, because after 24 hours, you will start rewarming the patient, because this target temperature management will be done only for 24 hours. Once you cross the 24 hours, you are going to start rewarming the patient. Once you are rewarming the patient, you can do an MRI after 24 hours. So which can show some changes, especially we used to see that gray-white differentiation in CT and MRI, and in FLAR also. You can assess a lot of things, whether the patient will recover or not. So that's what ultimately we want. So after 24 hours, we can do an MRI, we can do EEG. Especially in EEG, there are certain things which you can look for, especially if the patient is having status myoclonicus. Remember, this myoclonic seizures can happen after any neurological damage. So myoclonus is a very non-specific marker, but still it is a very powerful marker of neurological damage. It doesn't tell you that the patient is having only a post-cardiac arrest state, but if the patient is consistently having status myoclonus or status myoclonicus, it really means that the patient is unlikely to recover in this situation, because it's a very severe neurological damage. And apart from that, you have something called a N20 SSCP, that's called somatosensory evoked potentials, which will be done bilaterally. Suppose this N20 SSCP, if it is bilaterally absent, so in this situation, we are going to be extremely clear that this patient, this is having some 100% specificity that the patient is neurologically dead. There's no doubt about that. And it's having 100% positive predictive value as well, that the patient is neurologically dead and this patient will not recover. So you can try doing an N20 SSCP, or you can do some serological markers. These are blood markers of neurological damage. But there have been a lot of markers like chromogranin, but there is one marker that is extremely useful, at the same time having a high level of specificity, is the neuron specific enlace. That's called as NSE. That's going to have a very high level of specificity as far as the neuroprognostication is concerned. So once you have crossed that 72 hours mark, you can use clinical indicators of neurological recovery. Like for example, I can assess the pupillary response in the form of light reflex, and I can assess the corneal reflex. I can assess the pupils, I can assess the corneal reflex. Pupil means I am going for the light reflex. And I can see the size of the pupils, whether is there any change in the size of the pupils, and a lot of things I can do clinically. And plus or minus, there are some other things like motor response to a painful stimulus can also be assessed. So after 72 hours, you can start assessing clinically. But remember, it has to be done after 72 hours. Within 72 hours, these clinical predictors are very unlikely to predict the actual status of the patient. So it's better to do after 72 hours. And at the same time, EEG can also be very useful after 72 hours, which tells you extremely poor prognosis, especially if there is something called as a burst suppression pattern in the EEG after 72 hours, or if the patient is having a persistent status myoclonus even after 72 hours of ROSC, then all these things suggest that the patient is going to have a very poor neurological outcome for that matter. So you're not going to get a good neurological outcome in the first place. So within 24 hours, do a CT. After 24 hours, you can start with MRI, EEG, N20 SSCP, and markers like neuron-specific enlace. After 72 hours, you can use some clinical markers and again EEG to predict the neurological outcome. So this is something very important. Could be a question, potential question in exam. That is called as neuroprognostication, which is really, 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 really important. So we have discussed quite a few things. So remember, finally coming back to the important things that have been changed. So the one thing is this pediatric rescue breath, that is 2 to 3 seconds, 20 to 30 per minute. And next thing is that IV access is actually IV axis is the one that is more beneficial compared to the intraosseous axis. Previously told IV is equal to IO. Previously, cricoid pressure has been thought to be useful in patients, especially pediatric individuals. Currently, there is no role for cricoid pressure as far as any guideline is concerned. So many trials have proved there is no role for cricoid pressure during intubation or probably even during CPR, especially in the post cardiac arrest scenario. And typically the doses of the adrenaline has been re-emphasized, and as I told you, the adrenaline timing has been re-emphasized one more time. It's more useful in non-shockable. As non-shockable is concerned, it should be administered as soon as possible, but in pediatric it's been suggested that if you administer within 5 minutes, the survival and ROC is going to be much better. And the dose of adrenaline we discussed already. So as far as 1:1000 is concerned, if somebody wants to know what do you mean by 1:1000, it is 1 milligram per ml. So this is the dose that we recommended, that is 1:1000 adrenaline. And as far as the antiarrhythmics is concerned, amiodarone is supposed to be equally beneficial as that of lignocaine, which means lignocaine is considered to be non-inferior compared to that of amiodarone. Previously, we thought that amiodarone is better. And as far as the CPR quality is concerned, it's been suggested that objective CPR quality is better than subjective, even though I told you what are the ways to assess subjectively and what are the ways to assess objectively as well. And amiodarone can be repeated to a total of 3 doses. And epinephrine, you don't have any particular ceiling limit. You can give any amount of epinephrine as long as you continue with the CPR. And as far as the post-ROC care is concerned, so they have clearly given what are the targets that you need to achieve. But even though the ventilatory protocols are standard, you have to give an early endotracheal tube if it's not already there. And next step is to do an ECG, so to know whether the patient needs any additional cardiac management. And finally, you have to assess whether the patient is comatose or non-comatose. If the patient is comatose, then you can go for early CT and targeted temperature management, which is of course of extreme benefit, especially for patients who have achieved a ROC for that matters. And there are 2 types of cooling methods. One is surface cooling and core cooling, which I have clearly shown by the image previously some time ago. And as far as the neuroprognostication is concerned, at what timing you need to do what kind of markers, again, is a matter of importance, especially for the exams. And remaining all the things are almost the same. I think this must be enough. And one more thing that they have mentioned as far as the defibrillation is concerned, I mean, even though we don't give this something called as double sequential defibrillation, shock means there is something called double sequential defibrillation. So what do you mean by double sequential defibrillation? It is like delivering 2 shocks simultaneously, or at least near simultaneously. That's what we refer to as a double sequential defibrillation. Even in the previous guidelines, this was of very big doubt, but currently it's been clearly proven that double sequential defibrillation is not at all beneficial, and the routine shock, that single defibrillation itself, is enough rather than giving a double sequential defibrillation. This is not a surprise, because even in the previous guideline, this was considered as a level B evidence, in the sense like it's not that good. In fact, B2, it's not even B1 also, it's B2. They told probably maybe beneficial, but we need further trials, but we don't use in reality. But currently it's been very clear that this double sequential defibrillation is not at all beneficial, and you're going to only use a routine single defibrillation and nothing else as far as adults are concerned. And one more thing that's been given is that maternal cardiac arrest. Maternal cardiac arrest during pregnancy. This is a completely new thing. So this is completely unexpected as well in the guideline. So this is a completely new thing. This has not been there in the previous guideline at all, how to manage a maternal cardiac arrest. So there is not much difference as far as the adult cardiac arrest is concerned. You're going to use the same BLS and ACLS. You're going to try to achieve the same high quality CPR. There is no much difference as far as the maternal cardiac arrest is concerned. Then the most important thing is to find out the etiology of cardiac arrest. Etiology of cardiac arrest. As far as the etiology of cardiac arrest is concerned, they have given some mnemonic for that. So we have something called A, B, C, D, E, F, G, H. As far as A, B, C, D, E, F, G, H is concerned, A stands for this anesthetic complications, B stands for bleeding like postpartum hemorrhage, and C stands for cardiovascular causes like probably pulmonary embolism, we don't know. D stands for some drugs. Sometimes magnesium toxicity can be there, especially when you are giving for eclampsia. Hypermagnesemia can go for respiratory and cardiac arrest. And embolic complications, where thromboembolism is quite common in pregnancy scenario, because pregnancy is hypercoagulable state, we know that. And fever and sepsis could be the cause. And G stands for general obstetric causes of cardiac arrest, general non-obstetric causes of cardiac arrest, what you get in routine individuals, and H stands for hypertension, like eclampsia and all those stuff. So these are the different causes of maternal cardiac arrest that's been mentioned in the guidelines. And as once you know the etiology, or even if you don't know the etiology, doesn't matter. So you need to go for some maternal interventions, and at the same time you need to go for some obstetric interventions as well. Obstetric interventions. So as far as the maternal intervention is concerned, airway is considered to be a little more important, even though the chest compressions are more important compared to adult. Non-pregnant adults. This airway is considered to be relatively more important in mothers compared to that of the other non-pregnant individuals. And similarly, try to give 100% oxygen, and try to avoid overventilation. So why you have to avoid overventilation, especially mothers, is concerned because in mothers the diaphragm will be up because of the gravity uterus, and that will actually increase the intrathoracic pressure. If you do overventilation, the intrathoracic pressure may rise even further, producing a tamponade-like effect on the heart, resulting in reduced venous return as well, because it compresses on the great vein. So try to avoid overventilation. That's really important whenever you are trying to achieve a good outcome in mothers. Especially the IV axis should be above diaphragm. IV axis should be above the diaphragm. And why this is important? Because if you achieve an IV axis below the diaphragm, like for example, if you are giving a femoral line, the problem with mothers is the fact that the venous return will be very poor, especially in lying down position when you are trying to resuscitate the mother. The gravity uterus might actually press on the IVC and the great veins. So that what really happens is, if you're going to place an IV line below, there's going to be significant resistance to the blood movement through the IVC into the heart. So that is why it's always better that you give an IV line above the diaphragm rather than giving the IV line below the diaphragm. And at the same time, suppose if already on IV magnesium, if the patient is getting a cardiac arrest and patient is already on IV magnesium, then immediately stop IV magnesium, because it could be magnesium toxicity, because the most common cause of hypermagnesemia in the world is iatrogenic. We know that hypermagnesemia does not really happen without iatrogenic cause. So most common iatrogenic cause is pregnancy, especially during eclampsia. You give too much of magnesium, resulting in a poor reflexes and a cardiac arrest and a respiratory arrest. So stop IV magnesium as soon as possible, and you have to administer calcium chloride or calcium gluconate. So calcium is an antidote for magnesium toxicity. We know that. So hypermagnesemia can be treated in the same way like that of hyperkalemia. So the first step after knowing or probably telling it's hypermagnesemia is to give a calcium. So it could be in the form of calcium chloride or probably in the form of calcium gluconate. And you need to know some obstetric interventions as well. So you need to do some maneuvers to achieve lateral displacement of the uterus. In the sense, like you can try to push the uterus laterally. Because why you need to push the uterus laterally? Because to relax these veins, because they'll be under the compression of the uterus, especially if it is during the third trimester, it will be more gravid and will be pressing with so much of weight on the vein, so that the venous return might be poor to the heart, resulting in more and more cardiac arrest and more hypertension. So you try to achieve the uterus to a more lateral position. That's what we called as a lateral displacement of the uterus. And you need to detach all fetal monitors. There is no point in giving any fetal monitors, because the mother is already in shock and cardiac arrest, and prepare for perimortem delivery. Perimortem delivery in the sense we are going to do a LSCS, perimortem LSCS. And at the same time, suppose if the patient is having no ROC, if achieving no return of spontaneous circulation, you have done all these things, but if the patient has not achieved return of spontaneous circulation in less than 5 minutes, then immediately you have to go for a cesarean section. This is called as perimortem C-section. Perimortem cesarean section has to be performed immediately. Suppose if the mother, at least you can save the baby in this situation. That's the idea here. So they have given some typical time also. Like if you don't achieve ROC within 5 minutes, after doing all these interventions, you have given a BLS, ACLS, you have tried to give a shock, you have tried everything else. And if the patient has not achieved ROC despite all this whatever you have done, so then proceed towards immediate perimortem cesarean section. So after that, you need to achieve the neonatal care also. That is separate. That's not been emphasized a lot, but it's a standard neonatal care. Once the neonatologist comes, you can try achieving a standard neonatal care. So this is what has been suggested as a maternal cardiac arrest algorithm, which could be a potential question. But the most important thing is the fact that they might ask some crucial steps here, like avoiding this overventilation, airway, which is more important in maternal population compared to that of non-pregnant individuals, and IV access above the diaphragm. If on IV magnesium, to stop and give a calcium. There's lateral displacement of the uterus. If no ROC within 5 minutes, then go for immediate perimortem cesarean section. So these are some of the few points that can be emphasized in the exams and can be asked, because this is something quite new and this is something completely new in fact. So there is nothing that was there in the previous guidelines like this. So fine, I think we have covered almost all the new stuff in a great depth and detail. If you have any doubts, you can ask from this situation. From this, so that I can answer some of your doubts. Anything else you want to ask? No. AF with hemodynamically stable patient. We are talking about a cardiac arrest here. So AF with hemodynamically stable patient, we are going to treat it in the same way as that of other AF. So we are going to use drugs, and that's a completely different protocol. We are not going to really do something here. So I don't think that's going to be of any use. And one student is asking, can you summarize adults as well as children? Yes, I can. If you want to know what are things that are important for adults, you want to summarize, isn't it? So as far as the summary is concerned, number one, they have stressed on the early use of epinephrine, point number one, as I told you already. Second thing, what they have stressed is the IV is equal to IO access. So not much difference as far as IV or IO is concerned. And the third thing is the objective monitoring of CPR quality is better than subjective. Objective monitoring of CPR quality, or this is also referred to as something called as a physiological monitoring of, IV equal to IO was previous, but IV better than IO was a new thing. I told that, but just in a rush of blood, I wrote that. So IV is better than IO, that's what is being suggested. And this objective monitoring is also referred to as physiological monitoring of CPR quality through either EtCO2 or through intra-arterial blood pressure, whichever is feasible. So this is considered to be better. And number 4, there is something called, I told you, double sequential defibrillation, so which is actually not recommended, and they have clearly proven to be of no benefit. We know that. And they have emphasized a lot on neuroprognostication, which I have discussed in detail actually. So you can go back and see that neuroprognostication. And 6th is the recovery. So, and you can write on the 6th, why I'm writing as the 6th point is because this is the 6th chain of survival that's been added new. This could be a probable question. So the recovery that's been added. And 7th is the maternal cardiac arrest algorithm, which has to be known in detail because this is something that is completely new, maternal cardiac arrest algorithm. And maybe there are some 1 or 2 small changes that's been done. Is that they have told that CPR by lay rescuers, layman, layman is also okay. That's fine. So previously it's thought that CPR by layman is actually causing more harm than benefit, but there is no harm compared to the actual outcome of cardiac arrest. If you don't do a CPR, it's been very clear that even CPR is done by a layman with not proper knowledge. Even if they do some amount of CPR, it's invariably going to be beneficial. So clearly this is something not that important for exam. This is something that's been emphasized in reality. And there is something that's been changed, that is, that not changed, that is reconcerned, that is that real-time audio-visual feedback. There are many devices that can give whether you are doing a good CPR or not. Rather than assessing on the subjective markers, there are a lot of instruments that can give the real-time audio-visual feedback regarding the quality of the CPR, and that's been re-emphasized as well. And apart from that, that's all. So these are the most important things. In that, I believe the questions will be on epinephrine, IV more than IO, the subjective monitoring of CPR quality, no double sequential defibrillation, important neuroprognostic tools, recovery as the sixth chain of survival, and maternal cardiac arrest. So these are the most important things that they're going to ask. As far as the pediatric life support is concerned, there are not much changes. The most important change as far as the pediatrics is concerned is, as I told you, you are going to give the rescue breaths. That's the most important and the significant change. And this could be the question for sure. So rescue breaths, you're going to use 20 to 30 per minute, which means you can give one breath every 2 to 3 seconds. So that's the idea. Previously it was 10 to 12 per minute. That was 5 to 6 every 5 to 6 seconds. But right now it's increased to a higher value. And this has been shown to produce a higher rates of recovery. And second thing is, in pediatrics, previously cricoid pressure was something that was told to be okay, but currently it's been very clear that there is no need to give any cricoid pressure. So this is number 2. No cricoid pressure during intubation or during CPR, doesn't matter. And previously they have told that cuffed tubes is equal to uncuffed tubes. That was previous. Cuffed is equal to uncuffed. There is no much difference, so you can go for uncuffed tubes. But clearly right now there is a new guideline which clearly says that uncuffed tubes, are not superior, whereas cuffed tubes are considered to be a little superior compared to that of the uncuffed tubes. And similarly, as far as the epinephrine is concerned, previously they told in non-shockable rhythms, they told you have to give ASAP, but it's better if you give within 5 minutes, especially in non-shockable rhythms. So they're supposed to be very superior. So there was no timing previously, but currently they have told a particular time, especially if you give the first dose of epinephrine, that is adrenaline, within 5 minutes, it's supposed to be very beneficial. So this is one more thing that is being re-emphasized as far as the pediatrics is concerned. And apart from that, there's been small changes in the fluid boluses in the pediatric age group. As far as the fluid bolus is concerned, now it's been around 10 to 20 ml per kilogram, and it has to be given in aliquots. I'll show you maybe in the next cardiac arrest video. I will be trying to show what I mean by 10 to 20 ml aliquots, but it's better to give 10 to 20 ml aliquots. But previously it was around 20 ml per kilogram. 20 ml per kilogram. But currently it's become a little flexible to 10 to 20 ml per kilogram. That's the only change that's been made. Previously it was being given as a fluid bolus rather than giving in just as a fluid bolus. They didn't mention anything about aliquots. Currently they have mentioned on these aliquots as well. So that is one small change that's been made. Probably if you want to know, this 10 to 20 ml has become a little bit flexible cutoff rather than just by giving a 20 ml per kilogram cutoff. And as far as the vasopressor is concerned, there has been a small change, very small change in fact. They are telling epinephrine or norepinephrine can be tried in pediatric age group. Previously, they told dopamine also can be tried, but currently dopamine is something that's not been mentioned in the current guideline. Then apart from that, steroid use has been re-emphasized. This is something that was there already, it's just reaffirmed one more time, especially in patients who are having refractory septic shock. In children who are having refractory septic shock, you can use steroids. This is something that is there already. This is something that is, it's not like it's not there already. In any patient with refractory septic shock, there is a standard septic shock guideline where you can really give steroids, not a problem at all. It is just the fact that it is not mentioned in the ACC-AHA cardiac arrest algorithm, and that's been reaffirmed in the recent 2020 guideline. That's all, nothing else. But this is something that's already there, and every single practitioner has been using that. So that's not something new in the first place. So, but it's just that ACC-AHA has been told that steroid use for the first time in the new guideline. So that's all. That's why it makes a little bit of sense. Apart from that, it is there already. You can use corticosteroids in patients who are, any patient, for example, even adults or maybe children or infant, doesn't matter. In any patient who's having a refractory cardiac septic shock, you can actually use the steroids. Not a problem at all. And one more thing that was there in the new CPR guidelines is the separate opioid related cardiac arrest protocol. Separate opioid related cardiac arrest. I don't think that will make a real sense in Indian exams, because there is not much opioid uses as far as India is concerned. But there's been a separate guideline for managing cardiac arrest in patients who are using opioids, or post-opioid use cardiac arrest has been given in a separate way. But nevertheless, so it's going to have the similar kind of an effect only. So it's not going to have much of a sense anyway in exam. So I think we have discussed in great depth and detail. I hope the session was useful, and we'll try to stop with this particular